And welcome to this breakout session. We just had a fantastic case from Leipzig with a patient, a woman with aortic stenosis who had received a transcatheter aortic valve and needed a PCI. It was a fabulous case to get us into this, optimizing the therapeutic management of women with aortic stenosis, insights and implication from emerging data. This is in partnership with Women as One. My name is Roxana Mehran, one of the founders of Women as One, professor of medicine at Icahn School of Medicine at Mount Sinai, interventional cardiologist at the Mount Sinai Fuster Heart Hospital, as well as director of Women's Heart and Vascular Center there. I'm delighted to be chairing this session, and it is a huge pleasure that I'm joining this fantastic faculty panel. Sinjini Biswas from Royal Melbourne Hospital is here with us today. Hello, Sinjini.
Hi, Prof.
It's wonderful that you're here with us. We also have Marta Kaluzna-Oleksy from University of Medical Sciences from Poznan, Poland. Dr. Kaluzna.
Hello. Nice to be here today.
It's so good to be with you. And we're hoping to get Dr. Zainab Dakhil join us from University of Baghdad in Iraq, but she will do her best to join us. But I know there were some connection issues, but I'm certain that she'll be here with us. This is an interactive sessions that we have put together. We welcome you to submit your questions in the Q&A box under the video. We also we'll be asking you, the audience, questions to take part in. So pay attention. We want you to be there and converse with us in the Q&A box. In today's session, we'll be addressing some of these very important learning objectives, understanding the clinical anatomical differences in female patients with aortic stenosis, exploring sex-specific challenges in peri and post-procedural care for female patients, analyzing very important key findings from some of the female-specific valve replacement and aortic stenosis treatment, and examining the need for sex-specific guidelines in aortic stenosis diagnosis and treatment. So we'll begin with an interesting talk that I put together on pre-procedural screening and specific challenges for valve selection in female patients. Let's start with that. So important for you to note my disclosure specific to this is that I was one of the co-principal investigators of the SMART trial, and we'll discuss that. That was a small annular study for women, for men and women with aortic stenosis, severe aortic stenosis. So everyone knows the natural history of aortic stenosis. Asymptomatic for many years, and once symptoms develop, really huge decline in morbidity, mortality, huge issues. That classic triad of angina, syncope, heart failure still stands, and we might even be moving towards the asymptomatic population, because are they truly asymptomatic because of the data that we now have seen recently? What's important to understand is the incidence of aortic stenosis is actually similar in men and women, but despite this, there is much higher, women with aortic stenosis have higher long-term mortality than men. And this isn't patients who had intervention versus not, surgery or TAVR, it's all of aortic stenosis. So why is that? Maybe we're undertreating women, underdiagnosing them. Look at the UK National Registry here of 185,000 patients. The probability to receive an aortic valve replacement, whether it's TAVR or SAVR, is much less for women compared to men. And in the US Medicare database between 2013 to 2022, with 339,000 plus patients with TAVR, you see that the trends are higher for men compared to women. Why is that if the incidence is the same? And in fact, women are living longer, they're older, they even have higher incidences in a low advancing age of stenosis because they live longer. It's also important to understand that women are not just small men. It's not just because we have a small annulus that we're smaller, because the pathophysiology is different. There's less calcification, interestingly enough, and more fibrosis score. The annulus is smaller, but there is also a lower coronary height, and there is the geometry in terms of how the response to aortic stenosis is more of a concentric modeling, whereas in men, we see larger annulus, higher coronary heights, more calcification, less fibrosis, and more a mix of concentric and eccentric hypertrophy. And if you look at the aortic root anatomy, and it's the annulus that's smaller, but the left ventricular outflow tract is is also smaller, but it's a similar aortic dimensions. So it's very interesting to understand that there are important specific differences. What about outcomes when TAVR is actually performed in women? And we have this data from the TBT registry showing that, yes, women have higher rates of in-hospital bleeding and vascular complications and stroke, but their mortality is lower on a long term. So clearly important that women need to be diagnosed, treated, and they do very well with and in fact, if you look at a meta-analysis of women and men and looking at the very important 4 randomized clinical trials, women have low mortality with TAVR compared to SAVR. And that really might have a lot to do with the fact that they have a smaller annulus and are the surgeons not using the aortic root enlargement so that they can place larger valves there. And I think those are the kinds of things that we're hoping our surgical colleagues will do, especially in lower risk patients and younger patients. There are lots of trials, and I'm sure that in this session, we're going to hear about this, but this is a very important one. An all-women study of TAVR versus SAVR in women, the RHEA trial. This was with the SAPIEN 3 platform, 440 patients. 75% of these patients had small annulus, as you can imagine, and TAVR did better than surgical aortic valve replacement in terms of that important primary outcome of all-cause mortality, stroke, and, of course, rehospitalizations. So this is with a 1-year follow-up, and we're hoping to see term follow-up in this. So let's understand what we have to consider when we're looking at a woman who comes for a TAVR and a consideration. Before screening, obviously very, very important to look at the 3D reconstruction of the MDCT, the transthoracic, selecting the vascular access. Women have smaller iliac arteries, and of course, we have to be very, very closely paying attention to those peri-procedural considerations that have to do with the vascular complications, perforation of LV because of the calcification that may be even eccentric, and the risk of acute coronary occlusion because of that height, the coronary heights that we talked about. And then making important device selections, avoiding the need for a permanent pacemaker, enabling coronary access, and of course, using low-profile sheath and delivery systems. And then after the procedure, so very, very important for us to understand how to minimize that TAVI approach, tailoring the antithrombotic therapies, and even thinking about, especially after the DAPA, post-TAVR DAPA trial at ACC, maybe even considering better prevention and thinking about the LV remodeling and everything else, and that important hospital discharge and what we need to do for women and how we need to get them back, especially if we believe that there is patient prosthesis mismatch, evaluating that valve, surveying it closely. So as we move forward now to the next thing is this idea of the small aortic annulus. What is it? It is defined as an annulus area less than 430 millimeters squared. And we see it in about 30 to 40% of patients who present with severe aortic stenosis, more common in our Asian patients, and certainly much more common in women. And we also know that there is an important increased risk of AV gradients after TAVR and SAVR, and higher risk of patient prosthesis mismatch I just spoke about. And the predictors are female sex, small aortic annulus, and a small prosthesis valve size. And importantly, PPM is an important indicator of a worse outcome. So we need to avoid this at all costs whenever we can. And we have had some data that suggests that maybe a self-expanding valve could have, in a small annulus, could have a better outcome in terms of PPM or patient prosthesis mismatch that in annular devices. And I already discussed that PPM is an important predictor of MACE and mortality. This is from many, many studies, and we see this over and over again. So it is really important to have this in mind when you're evaluating a patient for TAVR, especially women who are at a very, very high risk of PPM because of small annulus. So let's take an audience poll. How familiar are you with the SMART TAVR trial and its findings? Very familiar, somewhat familiar. I know the basics, not familiar at all. I heard of it, but I haven't reviewed it. Please answer this, because I'm hoping that we could help you with this pivotal trial that was completely dedicated to the small annulus that happens to be in mostly women. And this is the SMART trial. The primary investigator on this was Howard Harmon. We presented this data at the ACC 2024. The co-principal, the co-PIs are myself and Didier Cheche. The trial was designed as a prospective randomized controlled post-market trial in 83 international sites. These were patients who would come in with symptomatic severe aortic stenosis and a small annulus. And they had to be amenable to receive either one of a self-expanding or balloon expandable valve. And there was a committee that made those decisions, especially with regard to the coronary height, the calcifications, et cetera, to be sure that given all opportunities, there was equipoise to place either a self-expanding or a balloon expandable valve. We looked at two co-primary endpoints, powered at 1 year and planned for 5-year follow-up. The first is a composite of mortality, disabling stroke, heart failure hospitalizations through 12 months. This is the clinical endpoint. The other co-primary endpoint, fully powered, was evaluating bioprosthesis valve dysfunction through 12 months. Now, understand, what does that really mean? It's an aortic valve area less than 1 centimeter squared, or a mean gradient greater than 40 millimeters of mercury, or a maximum velocity greater than 4. And of course, very, very important to understand that we did this very, very nicely. How do these valves differ? Are different? Of course, the Evolut Pro is a self-expanding valve, supraannular. It ranges from 17 or 18 to 30 millimeters. The valve sizes are 23, 26, 29, and 34 millimeters. This is a nitinol frame with a porcine tissue material, and it is recapturable. There is also a tissue sealing skirt to protect and reduce the paravalvular leak. The SAPIEN 3 and SAPIEN 3 Ultra, very well in its best configuration and tremendous input in improving this valve, is an intraannular about 60 to 28 millimeters is the annulus range, 20, 23, 26, and 29 millimeter valves. And remember, this is intraannular. So you see different sizes of valves, but understand that this is very, very important that they are not, they look like they're not equally the same, but they're actually, because of the intra versus supraannular, you're going to see different sizes here. The tissue material is bovine and the frame material is cobalt chromium, balloon expandable, and it's not capturable. Very important is this outer PET fabric skirt also to reduce paravalvular leak. The two co-primary endpoint results are here. This was presented in ACC 2024, published simultaneously in the New England Journal of Medicine almost a year ago to date. Morbidity, mortality, and mortality, disabling stroke or heart failure hospitalizations were absolutely no difference at all between the balloon expandable valve and self-expanding valve. This was powered for non-inferiority, and we showed and met this endpoint. So no difference in these important endpoints. However, we powered the bioprosthetic valve dysfunction based on the data that I showed you before, that there should be an improved and enhanced bioprosthetic valve function, so less valve dysfunction in self-expanding valve, and we met that endpoint with a powered superiority endpoint 12 months. So this was both HSVD, which is non-structural and structural valve dysfunction, and understanding the non-structural valve dysfunction would be severe PPM using WARC-3 criteria, and also, of course, important moderate total AR, and mean gradient being greater than 20 millimeters. So this is really important endpoint. We also tested all of these other secondary endpoints individually and looked at the mean gradient, less for the self-expanding valve for the 12 months, the EOA being larger for the self-expanding valve compared to the balloon expandable valve. And then you can see the HSVD and BVD, bioprosthetic valve dysfunction, which I already showed you, and then moderate to severe PPM, more prevalent in the balloon expandable valve. Importantly, no clinical difference whatsoever. And all of these hypothesis tested secondary endpoints met the superiority that they were powered for individually for the bioprosthetic valve function. Then I think I would say that if you look at the women's subgroup that we published in the JAMA Cardiology article, 86% of these patients were women. Large numbers of women included in this trial. The subgroup analysis showed the important improvement or enhancement of bioprosthetic valve function through 12 months in favor of the self-expanding valve for women, and no difference in death, disabling stroke, heart failure, hospitalization through 12 months between self-expanding or balloon expandable valve. Finally, I would say that the take-home messages here from this talk and in evaluation of patients with aortic stenosis, specifically women. Remember, women are not just small men. Unique features, small annulus, very, very important. The sex-specific guidance in planning the procedure before, during, and after, incredibly important. And being very much aware of the risks of adverse hemodynamics like severe PPM, low DVI, high gradients that is associated with a small annulus. TAVR may be superior in patients who have a small annulus and severe aortic stenosis. So maybe that's why we're seeing that TAVR superiority compared to SAVR in women. But when you're choosing a TAVR prosthesis, consider those important hemodynamic differences and whether or not they will have an important issue on their clinical outcomes, durability, and PPM is very, very important to follow these patients out to 5 years. We have yet to show that these, in SMART, that these changes in hemodynamic function have any important implication in long-term follow-up. We will watch for that in 5 years. And I want to thank you for your attention. Think about the differences in aortic stenosis between men and women. Thanks again. Let's now open this up. Oh, and I see that our team is back here. Thank you very much for being here. And it's wonderful to see you all. And let's go with Marta. Marta, what did you think about this, and what are your thoughts about this before we come to the multitudes of the talks that we're going to have?
I think it's really very important what you already mentioned, that we shouldn't treat a woman like a small man, and we should remember about the different hemodynamics, and especially for selecting for the valve. Of course, I would like to present in my slides the female trial, so it means REA trial, and I will try to show you also some differences which are very important, which should be really taken in mind if we prepare patients for undergo the TAVI procedure. But I'm really very happy that we discuss about these differences because we still do not. We see in a general registers that we still do not treat our patients, female patients with aortic stenosis, and the same way like male, because there are still the lack of procedures in this female population.
Well, let's see what those poll results show. So our audience, 10% very familiar, 35% they know the basics, 25% not familiar, and 30% they have heard of it, but they haven't reviewed it. So I'm really glad that we covered the SMART trial, but I'm going to actually turn this over because this very important concept of Peri and procedural considerations, a post-procedural consideration for female patients are very, very important. And Dr. Biswas from Melbourne is going to take us through that. Dr. Biswas.
Thank you very much. I'll just wait for my slides to come up. Beautiful. Thank you for the opportunity to present on some of the peri and post-procedural considerations for women undergoing TAVI. So this is quite a large topic to cover in 10 minutes. So I'll just briefly touch on a couple of aspects which have already been covered in the previous talk, but maybe talk a little bit more on detail on some of the practical things that we can do to improve TAVI or TAVR outcomes in women. So I'll talk a little bit about why sex-specific considerations are important, which we've already heard about, a bit about pre-procedural planning, both when we think about the route that we take in replacing or treating aortic stenosis in women, and then also about valve choice, again, and then focusing a lot about on the procedural risks and how we minimize these, taking into account the anatomical differences, and a bit about post-procedural management. So as we've already heard, why are sex-specific considerations important? Well, because women are anatomically different from men. Women tend to have a smaller annulus. They also tend to have a smaller LV cavity, lower coronary ostia, and also smaller caliber peripheral vessels. And therefore, it follows that procedural risks and considerations in TAVI must be different for women and men. We've already heard a bit about this, but I think taking a step back from TAVI, if we consider severe aortic stenosis as a whole, when we decide whether a patient should have a surgical AVR or TAVI, the central consideration in that decision is expected patient longevity, plus or minus surgical risk. Now, in the guidelines, if you think about it, age is generally used as a surrogate for life expectancy, and we generally recommend TAVI in those aged over 75 to 80, depending on which guidelines you look at, because at that age, life expectancy is approximately 10 years in those patients. But at any given age, women have expected a more expected remaining years of life compared to men. And so it follows that perhaps the threshold for recommending TAVI should be a few years older in women compared to men. Furthermore, the consideration about valve durability is then perhaps more, arguably more important in women, and we need to be thinking about lifetime management of aortic stenosis even more closely in women compared to men. Now, you've already heard a bit about the RHEA trial. I think there's a bit more coming later in the session. But just in brief, this was a international randomized trial of 400-odd women randomized to a TAVI with a balloon expandable valve compared to SAVR. And at 1 year follow-up, TAVI was actually found to be superior to SAVR with a lower incidence of death, stroke, and rehospitalization. And so this is, of course, encouraging data, but as has already been mentioned, more follow-up is needed to assess the long-term outcomes, especially pertaining to valve durability, particularly for women, as I've already discussed. So focusing now exclusively on TAVI, and of all the procedural considerations that we can make, I think TAVI valve choice is perhaps the most fundamental and significant. And as we've already heard, essentially we have a choice between two options: self-expanding supraannular valves or balloon expandable intraannular valves. And in women, we need to make this decision in the setting of the two anatomical features that we see particularly in women: a smaller annulus and lower coronary ostia. So I'll talk a little bit about the smaller annulus aspect and expand on this a bit further. So some of the consequences, as we've already heard, of having a small annulus is that there is a higher risk of residual post-procedural gradients through the valve and a higher risk of patient prosthesis mismatch, particularly in the surgical AVR cohort. And so therefore, this by principle has to play into valve choice. Supraannular self-expanding valves may be preferred because they are known to provide a larger effective orifice area and therefore also better hemodynamic performance. The other way in which this anatomy impacts the procedure is that there may be an increased risk of annular rupture. This paper has already been shown, but this is some data from the TVT registry, and it was what that paper showed was that the risk of annular rupture was higher in women compared to men. There is some data to suggest that the risk of annular rupture is lower with self-expanding valves, which may again play into valve choice in women. And again, for women, when we think about how we're going to do the procedure, given the rupture risk, avoiding techniques that further can increase this, such as excessive valve oversizing and aggressive post-dilatation, avoiding these things are going to be important considerations in how we perform this procedure in women. Again, we've already talked about the SMART trial, and it's great to have Professor Mehran, who's one of the PIs of this trial, here, and having already discussed this. But again, this is 700-odd patients randomized to self-expanding versus balloon expandable valves. And at 12 months, while there were no differences in clinical outcomes, biprosthetic valve dysfunction was lower in the self-expanding valve group in this cohort of patients, predominantly women, though, with small aortic annulus. A sub-study of this trial, as has already been discussed in women, has now also been published in JAMA Cardiology. And again, this showed similar results to the main trial in favor of self-expanding valves from a valve performance endpoint, again, though showing no clinical endpoint differences. So the other thing, moving away from the small annulus side of things, that we have to think about when we think about valve choice is that women tend to have lower coronary heights and also shallower sinus of Valsalva compared to men. And I guess surprisingly, one of the risk factors for acute coronary obstruction in TAVI is actually being female, as shown from this registry. We know from data from large imaging studies that the thresholds to be concerned about are a left coronary ostial height of less than 12 millimeters and sinus of Valsalva diameters of less than 30 millimeters. In the setting of these low coronary heights, especially if the sinuses are shallow, a supraannular valve platform may be preferred, although you have to, of course, bear in mind that future coronary access may be difficult due to the frame height in these platforms. In some cases, therefore, particularly in women, mitigation strategies such as chimney stenting or basilica may be needed to reduce this risk of acute coronary occlusion. So putting this together, what does this mean for valve choice in women? I think the jury is still out, and certainly there are no sex-specific recommendations in the guidelines, and really we do need more trials. So turning our focus now to more other procedural aspects, women more commonly have a smaller LV cavity size, as we've already heard, because they tend to get a bit more LV hypertrophy as AS progresses. And certainly we've seen in some trials that the risk of LV perforation is higher in women. So how can we mitigate against this? I think often we use now pre-shaped stiff guide wires, and certainly in my practice we use the safari wire, which fortunately comes in different size curves. And so often in women we will use the very small curve to try and reduce the risk of damage to the LV. I think arguably one of the biggest issues for TAVI in women is access management and vascular complications. We know that women tend to be smaller, they have smaller iliofemoral vessels, and therefore the sheath to artery ratio becomes higher. And their vessels also tend to be more tortuous compared to men. And this all adds up to probably the most consistent sex-based difference that we see in most TAVI trials and registries, whereby vascular complications are more common in women. Fortunately, the contemporary devices like the SAPIEN 3 Ultra and the Evolute FX are now using 14 French sheets for the majority of sizes, thereby making it more likely that we can perform transfemoral TAVI even in women who may have smaller peripheral systems. And this will also help, hopefully help reduce vascular complications in women in the future. Careful CT analysis is, of course, key to reducing vascular complications. And we now have access to adjunctive devices like intravascular lithotripsy, which may help to facilitate transfemoral access. I'll finish up by just talking a little bit about some post-procedural care aspects. We know that women undergoing TAVI tend to have more major bleeding, especially related to the access side, for reasons I've already just explained. And guidelines actually in general in patients with no indication of oral anticoagulants suggest they get a single antiplatelet agent, usually with aspirin monotherapy. But we know that even just aspirin alone is associated with more bleeding in women, but not men. Currently, there are no sex-specific guidelines for antiplatelet, antithrombotic use post-TAVI, but I think it's nonetheless important to be mindful of these increased risks in our female patients. And perhaps it may actually affect how quickly you immobilize women after a TAVI and other things like whether you choose to use protamine after a TAVI compared to men. So I'll just summarize by saying that, as I've said, the jury is still out on TAVI valve choice in women, although we have some early evidence that self-expanding valves may be better. Anatomical differences between women and men definitely need to be taken into account for both valve choice, but also thinking when you think about decisions that you make during the procedure, such as sizing, post-dilatation, what stiff wire you use. I think access site complications and bleeding still remain one of the biggest issues for TAVI in women, and although advances are being made in making delivery sheaths smaller, hopefully this will be less of a problem in the future. And again, hopefully also in the future, we will have more sex-specific evidence, which is now emerging, and therefore sex-specific guidelines to guide our practice. Thank you very much.
Wow. What a fantastic talk, and so comprehensive and beautifully delivered. You brought out such really great, intricacies, even with the wire, the safari wire with the lower curve. I mean, these were really, really good. I hope we're going to have some time to discuss this, because I think the safety of women undergoing TAVI has to be very, very importantly considered, especially given their peri-procedural complications. And then, of course, the sex-specific guidelines. Thank you, Dr. Biswas. This was really, really fabulous. And just because of time, and I'm really sorry, we need to turn over to Dr. Marta Kaluzna, who's going to talk about women undergoing aortic valve replacement. Over to you, Marta.
Thank you very much. And I would like to summarize these excellent talks which were already before me, and I would like to show why is the need and what are the rationale for the clinical trials which should be much more involved female patients with aortic stenosis. So we know that this underrepresentation of women in previous trials which were conducted in the patient with aortic stenosis. Of course, there was already shown that the SMART trial include more than 80% of female patients. Is excellent, and it should be it should give us the really the basis for the next discussion. We know that there are sex-specific differences in anatomy outcomes and complications in patients undergoing TAVI or TAVR, and it was already mentioned in the excellent lecture before. So we know that it's a growing we recognize that the woman may benefit a little bit differently or disproportionality from a TAVI procedure, but we must remember to implement in our everyday practice. So it was the need to conduct the trial only in female population. And the first one, which was randomized clinical trial comparing TAVI and a surgical procedure only in female population, was the RHEA trial. And we know from the history that there were a lot of trials showing us the comparison between percutaneous intervention on the aortic valve compared with surgical treatment. But we know from the epidemiology that aortic stenosis has the similar epidemiology as in a female and male population, especially in older population. So we know that we should have the same number of procedure in both populations of patient. And what we know from the previous randomized control trials and registers, that only less than 50% of women undergo the procedure due to aortic stenosis. So now it's the RHEA trial, which was presented at the ESC Congress 2024 and already published a few days ago in the European Heart Journal. So it was also mentioned, it was the investigator-initiated multi-center randomized clinical trial, which involved 12 countries, more than 30 sites, and more than 400 patients, female patients, because it was trial only in a female population. So women with symptomatic aortic, severe aortic stenosis were randomized 1-to-1 for TAVI or for the surgery. And the TAVI procedure was was done only with the sapien-free or sapien-free ultra aortic valve. So it was only balloon expandable valve. There were some exclusion criteria, like, for example, bicuspid aortic valve or very complex condition. So this enrollment was quite okay, and the study retention was very high because more than 95% in both of arms. So in a TAVI and a TAVR arm. And what do we know from the findings from this trial? That this population which undergone surgery, in not many cases, but there were some procedures which were much more complicated than only aortic valve replacement, because about 7% of patients undergo also CABG, but it was not a majority of patients. And what we know about valve size distribution in both of this population, they were the majority of patients in both arms had the aortic valve size less than 23 millimeter. And the study results was also already shown. It was excellent. The study was designed for non-inferiority, but it showed even superiority for TAVI procedure in comparison with TAVR in female population. And this primary endpoint was assessed at 1 year, so 12 months, and it was driven in majority due to the rehospitalization rate. Of course, there are some differences in the population. The patient undergoing TAVI need in more percentage of cases the need of pacemaker implantation, but in the surgery group that it was a high percentage of new onset of atrial fibrillation in comparison with TAVI group. There are also some secondary points which are very important and for the reason of quality of life of our patients. So the majority of patients undergoing TAVI were discharged to home, and the index procedure and median hospitalization was very, very low. So it means that the days staying in a hospital was almost, the median of the days was 4, and in comparison with 9 in a surgery group. And how cardiographic findings show us also the very small differences, but of course they were in a mean gradient and effective orifice area, and it was, the mean gradient was a little bit higher, and the effective orifice area was a little bit smaller in the TAVI group, but without a lot of huge changes in echocardiographic assessment. It was also very nice results in the quality of life, because at the 30 days after the procedure, there was a huge difference between this both group, and a much higher quality of life were assessed in patient undergoing TAVI. Of course, there is not so huge difference in the longer follow-up, and at the 1 year, there was not significant, but a little bit better in a TAVI group. And then we have also an additional information from pooled analysis of RHEA and partner-free trials, so the same valve used in both trials, and it was presented at TCT 2024, already showing us also the design was similar, so female patients were only analyzed, and it was a randomization, TAVI or surgery. And the primary endpoint was also the 1 year. It was also 1 year follow-up with the primary endpoints, which should be all-cause death, stroke, and rehospitalization, like a combined endpoint. What is very interesting from the partner-free trial analysis, that in the basic trial, so this partner-free, only the 30% of patients were included in the TAVI group, and even less in the surgery. But it was the pooled analysis of this both trials, only concentrated on female. The valve size was similar like in RHEA trial, so there are the majority of patients, as the majority of women has a smaller valve size than a 23 millimeter. And the endpoint, the composite endpoint, was also very excellent in better outcomes, showing in female patients undergoing TAVI procedure. And the secondary endpoints show us that these good results were driven also in majority due to the revascularization. The rehospitalization rate. The quality of life was very well, and we see here that this quality of life better exists also after this 12 months observation, and it was here a significant if we taken into account this pooled analysis. I think what we should remember all the time, of course, one is the prognosis of our patient, which is very important for us, like doctors, operators, but for our patient, the most important thing is sometimes the quality of life and how they can feel after the procedure which was done. And I think the take-home message which bring us the RHEA trial and also the pooled analysis of female patients undergoing balloon explantable valve is that this TAVI can be safe and effective option for low-risk women with aortic stenosis, and they are sex-specific. The sex-specific trials are critical to advancing personalized vascular care, and it was also very nice discussed that we have also a very nice results trials showing the same good option and the better prognosis in patient undergoing not only the self-expandable valve, the balloon expandable valve, but also for self-expandable valve. Thank you very much.
Hi everyone, this is Zainab Dakhil from Iraq. Today I'm going to talk about asymptomatic AS patients and the early TAVR trial. So why it's important to highlight this population? First, because AS is the most common heart valve lesion. It can occur up to 5% of the older population, and it has really unpredictable progression. The risk of sudden cardiac death in severe AS can reach up to 3% per year, and this is a large ratio. Regarding the current indication for intervention in this population, it's important to highlight that it's mainly depending on the echocardiographic parameters, whether the gradient or the change in the gradient, and also it depends on the functional status of the patient and the life expectancy associated comorbidities. And what we can see from the international guidelines that they are focusing mainly on these parameters, whether the ejection fraction, the symptoms at exercise test, or the fall in systolic blood pressure with exercise test, and the other echocardiographic parameters. Despite that, there is no complete agreement in all recommendations regarding their at what recommendation level exactly, but still the main focus are on these parameters. We can see also that even whether to choose a server or a TAVR in managing this population is mainly depending on the age of the patient, the comorbidities, and the surgical risk of the patients. However, there are certain data that emerged lately, and it's mostly from the randomized controlled trials. I'm focusing on two trials, first the Avatar trials and the early TAVR trial. And because these trials provide data that we think it will change the future international guidelines and how we will manage this population in practice. Regarding the Avatar trial, it's actually a multi-center, multinational, open-label, randomized controlled trial that recruited 157 patients that were divided into those with early surgery and the other group randomized into the conservative management with watchful waiting. The composite primary outcome comprising all-cause mortality, acute MI, stroke, or unplanned heart failure hospitalization, and there was significant decrease in the primary outcome within the early surgery group when compared to the conservative group. And when we see the subgroup analysis, we find that neither sex nor age nor other categorization of the patient according to their baseline characteristic actually change the results of this trial. The other trial is the early TAVR trial. And I will focus more on this trial because it's mainly percutaneous intervention. So in this trial, it was also a randomized controlled trial included more than 900 patients who were randomized in 1-to-1 ratio into those who had TAVR versus those who have clinical surveillance. And they were followed up for 2 years post-randomization. When we compare the baseline characteristic, we find that regarding the functional status, they are almost the same, the two groups. But regarding the other clinical comorbidities, we find that the TAVR group has more comorbidities when compared to the clinical surveillance group. And when we see the outcomes, we can see that there is a significant decline of 50% within the death, stroke, or unplanned hospitalization for cardiovascular causes. And this is by 50%. This is huge. Also, there was a 40% reduction in death, stroke, heart failure hospitalization with early intervention group. And it was interesting to find that stroke occurred more within the TAVR group when compared to within the TAVR group when compared to the clinical surveillance group. And it's also interesting to find that many of the outcomes that were really calculated within the end composite outcomes are emerging from the unplanned hospitalization for the cardiovascular causes. We can find that within the group that didn't undergo the TAVR, those with clinical surveillance, there was a significant increase within the conversion to what's called to the aortic valve replacement due to what's called acute valve syndrome or progressive valve syndrome. And we will explain that later in details. So when the symptoms started, there was a progressive increase and rapid deterioration of this population, which necessitates an intervention. And most of those who had the intervention were actually symptomatic. So by 2 years, 70% of patients within the clinical surveillance group underwent the intervention. And the median time to conversion was 11 months, with 26 required the aortic valve replacement at 6 months and 47 at 1 year. And if we classify the presentation and the progression, it was either a progressive valve syndrome, mild progression with some symptoms of heart failure, and the acute valve. And this is the patient presented here acutely with pulmonary edema, arrhythmia, collapse, heart failure, acute heart failure. And we can notice that at each 6 months increase, starting from 0 follow-up to the 18th month follow-up, at each 6 months, there was a 40% converted rate of this population from those who were asymptomatic to being really symptomatic and highly symptomatic patients. And with further sub-analysis that was just presented at the ACC 25, it was found that when we compare the group with a delayed TAVR population, we can find that they have a poorer outcome regarding their functional capacity, regarding the 6-minute walk, increase in atrial fibrillation, and increase in the biomarkers, and even worsening within the echocardiographic parameters. So when the analysis was adjusted for the age and sex, the delayed replacement group with acute valve syndrome was associated with a 2-fold increase in death, stroke, heart failure hospitalization, and a 3-fold increase in stroke following the procedure compared to the early TAVI. And if we take as the analysis as overall, when we compare the early TAVI, if we take each outcome, maybe it's not statistically significant, but if we take the progression according to the clinical progression in those who had the conversion, we can see that the acute valve syndrome, when compared to the progressive valve syndrome, when compared to the early treatment group, there was a very significant increase in all-cause death within the acute valve compared to the others. Also, a significant increase within the death, stroke, hospitalization, or death and stroke. So when we take the clinical presentation and the conversion in details, we see this trial informed us a lot about the progression of the watchful waiting group. And we need this data to inform our practice. So the early TAVI offers actually better outcomes than the delayed intervention. And it's important to notice that this will inform us, at least within the watchful waiting group. We have to do the early referral, early planning, early assessment, the imaging, everything should be planned ahead so that when the patient collapses or progresses rapidly, we are prepared. And regarding what to choose for managing this population, because this is a lifetime management, whether to choose TAVR over SAVR, we can see that there is an increase within the use of TAVR. If we see that on a temporal trend in many of the registries within the latest years. And also we can see that whether the risk of the patient, the surgical risk, their comorbidities, the age of the patient, all that can determine what to choose. But if we want to actually determine in more patient-centered approach, we should consider the valve size compatibility and the anatomy, also the durability of the valve, the patient health and comorbidities, and the patient choice. And when we compare the TAVR versus SAVR by many studies, including this meta-analysis, we found that there is no difference except from the pacemaker implantation, which was more within the TAVR group compared to SAVR. Otherwise, the death stroke was not really significant. So, to conclude, emerging data suggests that among patients with asymptomatic severe AS, early TAVR was beneficial, and wait and watch shouldn't be the default strategy in managing this population. Choosing SAVR versus TAVR needs thoughtful consideration for anatomical, clinical, durability issue, and patient preference. Thank you very much for your time and attention.
Oh, fantastic. Well, what a fantastic session. Unfortunately, we have no time left, but Women as One is so proud to have the four of you here, the four of us here, the three of you and me. But thank you for those great talks. Only TAVR, when there is aortic stenosis severe, take care of these patients, especially if they're women. Let's make the diagnosis of severe aortic stenosis. Let's make sure that we do special sex-specific consideration for peri-procedural and understand how to deal with the small annulus and that coronary height and the LV hypertrophy, everything that was talked about. Thank you so much for your tremendous input on all of this. I know our audience loved this session. Thank you for being with us. Women as One is thrilled to have all of you. And thanks to the sponsors and to, of course, Radcliffe for having us. Bye, everyone. Back to the main program.